CataractCoach.com podcast series, episode number 52 with Dr. Deepinder Dhaliwal, incoming president of the ISRS. Welcome back to our Cataract Coach podcast. And today we have a very special guest, one of my favorite ophthalmologists who teaches me so much and is not afraid to tell me like it is and poke a little bit of fun at me too. That is Deepinder Dhaliwal, professor at University of Pittsburgh, cataract cornea refractive specialist, also president-elect of the ISRS. Welcome, Deepy.
Aw, thank you, Uday. I am truly honored to be here today.
Oh, it's my pleasure. Now tell me about your work with ISRS, because you get some big changes here.
Oh yeah, ISRS is going to be bigger and better than ever. We are super excited to launch the next chapter of our career as a society. And you know, we're the oldest refractive surgery society in existence. We were founded back in the 70s by the true pioneers of refractive surgery like Jose Ignacio Barraquer, Kaz Swinger, you know, all the Troutman, I mean, all these amazing names. And the important thing is that we were independent. We had a little bit of financial difficulty. So the academy was fabulous and they took us over for 20 years. And now we're ready to be independent again. And we started our independent phase on January 1, 2024. So now we are independent once again. And we thank the Academy for all their wonderful shepherding through the past 2 decades. And really, it's been a fun adventure to be on our own again.
That's fantastic. So ISRS, International Society for Refractive Surgery. Are you going to have meetings then across the world? Tell me what's planned. When's the first inaugural ISRS standalone meeting?
Well, we're the hometown of Professor Barraquer.
Wow.
You know which town that is?
Somewhere in Colombia.
Not quite.
No?
Barcelona.
Oh, Barcelona. Oh, that's right. I'm thinking something different.
No. Well, he practiced in Colombia for many years, but his hometown is actually in Barcelona. So the ESCRS meeting is happening in the fall, and we are so really again honored to have a collaboration with the ESCRS, and we are going to have a joint refractive summit on the Friday before ESCRS. So that's going to be our
I will have to sign up and attend.
Absolutely. We are very, very excited and pumped about this next phase. So we're just really going to be nimble. We're going to be really responsive to our members. We still have the amazing member benefit of the JRS, the Journal of Refractive Surgery, and our website is isrs.online. So come visit.
We will put a link down below for that, and we look forward to it. I definitely want to come to Barcelona. That's a fun time.
Indeed.
I'm sure I'll learn a lot too.
Absolutely.
So then the future meetings will be then with kind of in combination with another big meeting like ESCRS or ASCRS or Academy. How are you gonna plan that, or not known yet?
Well, where do you want the next meeting with Devgan?
Let's go somewhere fun.
Okay. See, let's do it. You let us know. Like, this is the time. We want to really listen to our membership, and our membership is truly international. So we could go fun. We could do different continents. Like, we are basically in the planning phases. So we are international, 100%.
I think that's a better move for you guys, instead of being, kind of shepherding with the AAO, which was great for a while, but to break away and have your own separate meeting and then choose different countries, because you are truly international.
Absolutely. There you go.
Well, then you know what? You got to do something in Asia.
Okay. You let us know. We're ready. We are ready.
You got to do Asia. You got to do South America. You got to do Europe. You just got to spread it all around.
I think that's a fabulous idea. Those are ideas that we are talking about now. And again, we really want more membership participation. So we're forming really exciting subcommittees and really going to re-energize the society.
I really look forward to being more involved then. So for a young ophthalmologist, our podcast skews towards the younger groups, 30s and 40s are typical ophthalmologists who like to listen to our podcasts and watch our videos. How can they get more involved, and how do they find out more? We'll put the website link down below. What are the benefits for a young ophthalmologist? Let's say I'm a 30-something-year-old ophthalmologist, just started practice, want to do more refractive surgery. What's the benefit of joining your organization?
Oh, what a great question, Uday. So, the starting a refractive surgery practice, as you know, right, requires a lot of ecosystem. You can't
Right.
just say, I'm fellowship trained in refractive surgery and I'm ready to go. No, you need business acumen. You
Mhm.
need to understand who your referral sources are going to be. You need to understand the flow. You need to understand financing. You need to understand, where are you going to do these amazing surgeries, right? Are you going to go to a surgery center? Are you going to buy that equipment? So the key thing is, we want to help a refractive surgeon figure it all out and help them to be kind of the best version of themselves, whatever that looks like, whether it's private practice, academic, etc. So we are going to have different subcommittees. We're going to have different mentorship opportunities. And I think the critical thing is that by being a member of the OG Refractive Surgery Society,
Right.
ISRS, you have the world pioneers of refractive surgery, the best business minds in refractive surgery as members. And the key thing is that when you come to meetings that are a little bit smaller, on the smaller scale, you can actually approach somebody like
Right.
Uday Devgan and ask him for advice. But you can actually just email and say, hey, I'm interested in this. I have some questions. Can you help me? And boom, you can get that. But we will have a young refractive surgeons
Oh,
kind of
nice.
subcommittee, so that we want to enable a young surgeon to actually grow in a society, to get more leadership experience and to get those roles. We don't want to be like, the old fogies, on the board
Right,
forever.
of course.
No, we don't believe in that at all. So we want to have really shepherd our youth. These generations, they're our future, right? We want them
Right.
to have the best foundation, the best resources, so they can really fly.
Mentor the next generation, and so you can eventually pass the baton to them.
Absolutely. Absolutely. That's what we're all about. We are all about collaboration, sharing, teaching. And even to the point of, we have these kind of mini fellowship tracks. So if you just want to go and visit a surgeon, I need to learn that phakic IOL a little bit more in depth. Can I, come and watch you in the OR? Sure. That's part of the benefits as well.
Oh, that sounds fantastic. That's really neat. Yeah, I'll have to look into it a lot more and definitely want to be involved. How big do you think the meetings are going to be? Like, how many doctors do we expect? Any
That's
guess?
that's a good question. I mean, we're not exactly sure yet. It's since it's our first foray into having our meetings internationally, right? We're not 100% sure of the exact numbers, but the more the merrier, of course. And we want to always, though, maintain the feeling of a smaller meeting, because you know how valuable that is, right?
Right.
That energy, that special kind of vibe that you sense when you're in a smaller meeting,
Right.
where
Yeah,
people
yeah,
are
yeah.
just so excited to be there, and everyone's very accessible, and everyone is there because they want to be there, right? They want to learn, they want to teach, they want to share. So we don't want to ever lose that vibe, but we're going to scale up and down as needed. And we have a lot of sessions in our partner, sister, and brother societies, so that, like, for example, in Cartagena, Colombia, we are going to have a meeting in, I believe it is in August, late August. So one of our societies, the Colombian Society of Refractive Surgery, is hosting a session for refractive surgery, and ISRS is going to co-sponsor
I
that.
will be at that meeting. I've already been invited by their Columbia Society, so I will be at. Yes.
Okay, so you'll be a part of our ISRS session.
I will be there in Cartagena. I'm looking forward to it.
Perfecto. Okay.
Although when I go to Spanish-speaking countries, I speak my Los Angeles learned Spanish, which is
Yeah.
very much a Mexican dialect. So it always throws people off, like, wait a minute, how do you speak Mexican Spanish? It's a little bit different, right? It's like speaking British English versus Australian English or American English. It's a little different.
You know, it's all Greek to me, baby. So I don't know. No, I still am aspiring to learn Spanish. I think
Well,
it's
it's such a beautiful language. You know what you love about it? It's so logical. They're like the same rules. Unlike English, where English is a little bit illogical and like you write it often differently than you'd say it. In Spanish, you know, it's like it's straight. You write it the way you say it. It's all done. It's no questions. The rules are the rules. It's actually a beautiful language.
Yeah. No, I totally agree. I can. I'm trying to learn. Trying to learn.
And that's why ISRS really kind of emphasizing the I part, the international part, which is
Yes.
really great.
Yes. Yes, indeed. Indeed.
And I think that mentorship is so important, especially because if you look now in your residency, there's very, very little refractive surgery. I mean, when I was a resident way back when, I was the first resident at UCLA to ever do LASIK. And the reason why I was allowed to do it was my mentor, who's now the chairwoman at UCLA, was Ann Coleman, and she's a glaucoma specialist. And I just told her, Dr. Coleman, I'd really love to do LASIK. I think it's important that residents learn. And this is like 1997 or something, or 8. And I said, you know, would you go to bat for us residents with the department and make sure? And she did. She went to bat for us, and she made it so that we were allowed to do LASIK as residents.
That is,
I did 4 eyes.
That's amazing. And you started with the mechanical microkeratome,
yes.
Right?
Oh my gosh, yes.
Wow. Uday, I knew you were brave, and now your image of my image of you has just elevated. If you could use a mechanical microkeratome from those days, the automated corneal shaper, right?
That was one, the ACS. There are a whole bunch of different ones.
The ACS.
The amazing thing was too, even the lasers were these older broad beam lasers. And so how did you treat astigmatism? There, believe it or not, there was an ablatable mask that you put in front of the laser path, the laser beam, that would help you treat this. It was so amazing that we could do it back then. And it's so antiquated to what we're doing now. It's amazing.
It truly is. But isn't it fun that we were there when it all started? I think that's what's so exciting, is that we were part of refractive surgery at the very beginning of the FDA approvals of the excimer laser and of the, all these different iterations of microkeratomes. And now, we just use lasers for femtosecond lasers to create flaps, and we no longer use microkeratomes. But having that, even the incisional refractive keratotomy knowledge is super important to really understanding how to think about the cornea. So having that is just that historical knowledge, and that's another part of the benefit, right? You need to really understand the history to understand how to move forward. So
yeah, so you're right. Even though we do different things, so many important lessons from back then.
Exactly.
In fact, one of them, even I remember when I was a med student, I worked in the lab of Peter McDonald, who at the time was a faculty at USC.
Oh.
He then went on to Irvine. Now he's chairman of Wilmer.
Yes.
But, we had this rabbit studies where you'd basically do PRK on rabbits. This is, probably mid-90s. And then we'd see which eye drops, which post-op medications would slow down epithelial healing. And so we learned from that. Like I learned from that, the aminoglycosides, like the tobramycin, would slow down epithelial closure rates in those rabbits compared to, let's say, a fluoroquinolone. And so now recently I had a patient where I did PRK for her, and she's had a severe allergy to fluoroquinolones. So I said, should I put her on tobramycin? I was like, probably not. Because I remember from way back when.
Exactly. It's amazing, right? It's amazing.
Yeah, so technology is obviously getting better and better. We're now, of course, doing all laser-based in most cases, although I used a mechanical microkeratome to do LASIK a few months ago. I had a patient with the radial keratotomy, and the cuts were so kind of wide. I was afraid if I used the femto that I'd end up separating out the cuts from the RK. So the LASIK flap actually was really clean. The crazy part was, though, it made me so bananas, is that the patient was -1 in this eye. And they really insisted upon being corrected to Plato. And I was like, gosh, -1 is such a gift. How do you not understand this? So I made them delay it for a few months until we finally did it. I was like, okay. And they're super happy now.
Okay, so, until next year, and then they're going to be a little hyperopic.
A little hyper.
Uday, hello.
No, but luckily.
Say no. It's okay.
Okay
It
to say no,
really
huh?
is. In that case, 100% would have convinced the patient that it's in their best interest not to do a LASIK touch-up for a -1 in an RK patient. Because consecutive hyperopia is a real thing, progressive
Yeah.
hyperopic shift. And you're right, -1 is a gift. It's an absolute gift. And
Good for
having a
you and me,
multifocal.
but sometimes patients don't get this. So,
Ah,
honestly, the point is you got to tailor to the patient. So we make all different decisions. In fact, one thing I love about you is how you will say, no, I disagree with you. I would not tell you. I love that about you. In fact, our listeners may recognize the name Dr. Dhaliwal. Yes, from the Cataract Coach Best of session at the ASCRS. You and Rosa Bragamilia are my panelists, and I choose you guys specifically because obviously you're amazing surgeons, incredibly smart, smarter than I ever was, and more importantly, are not afraid to teach me on the podium in front of everyone else about the mistakes I'm making.
we truly consider you a brother. You really are a brother from another mother. And we have so much fun doing those sessions and the learning and the teasing and the laughter kind of nonstop. You're absolutely right.
Right.
And I think that when you get to a certain point in your career, you realize, you know what? You just got to tell it like it is, because this is the truth, right? Like, this is really how I do things. I used to be kind of scared to share, oh, I would never do that. That sounds crazy. And, you kind of want to just go along with everybody else, but definitely now,
Tell it like it is.
I just tell it like it is, because that's all I got,
Well, I love you. You give advice from the heart and from the brain. You're just like, this is my heart telling me this, my brain's telling me this is what you should do, and I think you did it wrong. But we have fun. And you're right. It's a 90-minute session of just like fun, and it's fast paced. I love how fast it is.
It's fast. You cut us off all the time, and I'm just like always thinking, oh, I hope I know what I would do in this case, because just so for the audience, Rosa and I never see these cases ahead of time. We are watching just like everybody else.
Right.
And you put us on the spot. And if we don't know the answer, you just keep on going, because the video never stops.
Right. So yeah, exactly. I don't let you or Rosa see the case ahead of time. So it's all going to be absolutely surprise to the audience, plus a surprise to you.
Yep.
And then the other part I like about it too is that, we time it very, very accurate. So for this 90-minute session, there'll be 9 cases, each one about 10 minutes total. And then, a little bit of video, then we have a discussion, a little bit of video, more discussion, and what would you do? And I've actually incorporated now some audience time, so audience can have Q&A.
Oh.
So throughout the thing, a little bit, but just a minute at a time. But you're right. I have a timer on the screen for everything. And when it says panel discussion and you have 1.5 minutes, I promise when the timer goes back to 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, we move on. There is no stopping, no pause.
That is correct. So there is no time for Rosa and I to actually think about the case or think about our answer. We just got to start talking. So it's kind of, it's quick. We got to be quick. Yeah, I definitely I have 2 cups of coffee that morning. 2.
Right, me too. You have to, because we want to get through so much. And so what I do is I make the entire 90 minutes. There are no PowerPoint slides. The entire 90 minutes is a single video file of 89 minutes in length. So we will for sure be on time.
How do you do that, Uday? Does that take you?
And that's the right way of doing it for presentations on the podium, to stay within your time. Instead of doing PowerPoint and clicking a slide and having it so variable, just having all the PowerPoint slides, everything incorporated into one video file. And then you hit play, and then for sure you'll never be over. So if I'm giving a talk that's 8 minutes long, I'll make a video that's like 7 minutes and 45 seconds. I go on the podium and say, hit play, and I just start talking. And for sure, I'll be done exactly within my time.
Yeah. So. Okay. One of these days, I need to have a lesson on video editing, expert video editing. Yours are always masterful.
Yeah, not easy.
And you're teaching, Uday, I have to say, your videos, your teaching, and your voiceovers, perfect. I mean, I learned so much, and you just you have this cadence, and it's just fun to watch. I mean, really, it's kind of just hanging out with Cataract Coach. When you just have an extra few minutes, it's just really, really.
Oh, thank you. Well, we're going to feature your podcast coming up on a Sunday, and then I'll give you the opportunity on the following Monday to have the Cataract Coach surgical video be about you. So which case are you going to submit to me now? You got to think about it.
Ooh, I already know.
Tell me.
I'm going to teach this super easy way to do phaco, and it's called squeeze chop. And all you do, and I know because I made it up. So
what's squeeze chop?
Squeeze chop is literally the easiest way to take out a cataract and one of the safest. And it works for almost every density of cataract. And it doesn't matter if the endothelium is about to fail or whatever, what the zonules are loose, it works everywhere. And you don't have to worry about vacuum. So all you do is you go in, and you, after your rhexis, you do a beautiful cortical cleaving hydrodissection and hydrodelineation. Then you make one nice central groove and you crack it. Then you turn it. And what you do is you take your, I just use a Drysdale because I'm still looking for something that I like better, but I take the sharp and my phaco tip. I use a 45-degree bevel phaco tip, and I impale it into the center of the half. And then I take my Drysdale and I go around the nucleus, and I just bring the two together to squeeze them together to chop, but I don't use any vacuum. There's no vacuum. See? So it's just literally mechanical squeeze and then chop. And then
you trap the heminucleus between the phaco tip and, let's say, your second instrument.
Yes.
And then you don't need to worry about vacuum even.
You don't worry about vacuum. And so you just squeeze, and then it chops and done. And then you take the little Drysdale, flip it out, and your phaco tip stays right in the center. And then you leave that one quadrant intact, and you turn the rest of the nucleus around so that you have the stability of the capsular bag from that one remaining the quadrant. And then you do the same thing on the other half without any vacuum. And so it's like so stable. There's not as much fluid, because I see when people try to impale it, then they're losing the piece, and then they impale the posterior capsule sometimes. And this is so simple. So simple, and boom, 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 and you're done.
Right. You got to send me that video. We'll feature it. Yeah, I think that's smart, because when you impale it with the phaco probe and use high vacuum to hold the piece, the catch there is that you now have a time window of 1 or 2 seconds before you lose the vacuum. So you have a time constraint. Whereas this, there's no time constraint. Place your phaco tip to hold the nucleus, just touching it. Chop or second instrument around it. Trap the piece between the two, and then just chop.
And there you go. Squeeze, chop.
I love it. All right, we're going to speak to that. This will, if you're listening to the podcast, it's tomorrow's video on CataractCoach.com. You definitely got to check it out. That's fantastic. I'd love to feature that. Let me ask you another question. I have a patient coming up. Brunescent rock. Like the patient, let's say, is 85 years old. The cataract is an absolute rock, like one of the densest I've seen in my career. Patient has a corneal pachymetry of 620 microns. Endothelial cell count of like 1,000 cells per square millimeter. What do I do?
Your best case, your most gentle case, whatever that is, right? So you got to bring your best game. I mean, for some people, it would be M6.
That's what I'm thinking. I'm just going to do
For some people, it would be that. Like, if you got that in your toolbox, then pull it out, right? Because you're just going to, there's no phaco energy. It's going to be a beautiful case. But if for those of us, and luckily I did learn that technique and I love it. And really, we used to do extra caps, remember? So it's just a modification of an extra cap. We all know how to do scleral tunnels. It's not that hard. It's a beautiful technique. Everybody should learn it. But if you don't know how to do it, you could use a MyLoop, you could use a femto, you can use all these different things to help you, or you could just do a vertical chop, right? And you can get that cataract out. But when you have a challenging case, I think the critical thing is bring your best game. This is not the time to start learning new techniques. This is not time to just watch all of Dr. Devgan's videos and try to implement that. You really want something that you've done before so you can really do it well, right? There's not many of us who can just watch and then bring our best game the next day for a compromised cornea case, right? A lot of us, you get better by doing. So you want to get a few under your belt. So that's what I would do.
Yeah, I'm going to plan on doing M6 because even if I chop the cataract up in the bag and did vertical chop, whatever else, it's still like that's a lot of phaco energy for a real wimpy cornea.
Exactly. So just do M6. I mean, that's the most gentle technique in this situation.
Plus, it's fun.
It is. It's like delivering babies, right? Like,
Right. It's the closest thing we're going to get to it.
Yeah.
So
It is fun. It is fun. And again, like we were talking about, it's just fun to be in training when we were still doing extra caps.
Right.
And like we were there when the phaco, that whole phaco wave, and we went from scleral tunnels to clear cornea to this, to that. And so, when we do these complex cases, it's like, been there, done that. We have all those tools. It is fun. It's kind of joyful to bring all those tools together to help.
Yeah, M6 is such a better procedure, though. I remember when I was a resident seeing those extra caps with the corneoscleral scissors to the left and the right. To cut that limbus with scissors is so barbaric.
Well, I used to use the crescent to just gently enlarge. And so, yeah, no, 100%. M6 is definitely better. It's just a better incision. 100%.
Yeah, tough case there. Oh, I got to ask you about more cases. Now that I got you here. Now, tell me what you had a very early experience with, as crazy as it sounds, pediatric refractive surgery.
Oh, yes.
Tell me about that. Like, you were the pioneer of this.
Well, I was one of the pioneers of this. And, I thank you for bringing that up. I think that we did a study back in 1999 looking at pediatric LASIK for children who were failing amblyopia therapy, and they had basically anisometropic amblyopia. So their one eye was not so nearsighted and the other eye was severely myopic. And so what we did is we did LASIK in their more myopic eye to balance the two eyes together. And it took forever to get through the IRB and this and that. And we had this amazing team. We did a pilot study and we wanted to know, how did these kids, how would they fare if we did that treatment? Because they were going to not see.
How old were the kids?
They were from ages 5 to 8.
So how do you do the anesthesia? You got to have some kind of anesthesia.
That is correct. Well, we did general anesthesia for these children, and it was really amazing.
In the excimer laser suite.
Yeah.
Wow.
So we had an amazing team of anesthesiologists. I still remember Ryan Cook and Peter Davis. I went to the Children's Hospital and met with Ryan Cook, and I said, we want to do this kind of crazy study where we're, going to do LASIK in these children. We need general anesthesia at the Eye and Ear Institute, not in the hospital. And he looked at me, he said, how long would it be? This, that. He's like, sure, I can do anesthesia anywhere, because he was in the military. And so he took this as a challenge. And it's because of him that actually we could do this study, because he was all in. And so we did this study, and what we learned is that you just can't use a mask to anesthetize these children. Because I thought, we'll just do a mask. We don't have to
intubate them.
No, but what happened is there's too much leakage of the anesthetic gases into the atmosphere, and our laser shut down.
Oh.
So I wanted to crawl into the earth when that was happening, because our study was derailing. But then we learned we needed to do an oral, like a laryngeal mask airway. And so with that, they were able to, safeguard the airway, and there was no leakage of the anesthetic gases, and we were successfully able to do all these children. So then we did our study, and it was really, really exciting. And I followed 2 of them. So I saw them 16 years later, and they still are so happy that they had it. So these children did very, very well. None developed ectasia. They were relatively well centered, even back then, considering we did mechanical microkeratome and, surgeon fixation. There was no autofixation. And it was a really amazing learning experience. And now I think there's still a role for this, for therapeutic refractive surgery. And, looking at even the next step, with the myopia epidemic, what can we do for these children who are rapidly progressing in their myopia? It turns out probably spectacles is not the best thing to give them, right?
Right.
When you give them myopic spectacles, they just keep on getting worse and worse. So we really need all of us as refractive surgeons, as cataract surgeons, as ophthalmologists. We need to understand myopia control, and we need to advocate for for the youth, for these children who are progressing. There's atropine drops, there's special contact lenses that they should be in. There's, orthokeratology, there's MiSight contacts, there's all these things. The key is do something and be outside and play outside in the sun for at least.
Maybe don't give the 2-year-olds and strollers iPhones to play on all day.
Yeah, that. Right. So, we really need to intervene. And so, even to the point where, maybe we should be doing refractive surgery on younger and younger children, just for the myopia epidemic. That's something that we're still investigating, and we're thinking about what would be the best ablation profile. That's another subcommittee as part of ISRS, is a myopia control subcommittee. And Alexander Stoyanovich is leading it. So we have a lot of interesting, really interesting kind of subcommittees and these task forces that we want to implement.
Yeah, if you think about it, for these cases of the anisometropia, it makes so much sense to, even the 2 eyes out to stop that issue of amblyopia.
100%. Think about these children. They're not getting the proper glasses. They're not getting proper just care, right? And so then they go to school, they can't see, they can't perform well. Their whole life is affected.
And then if you have anisometropia, let's say more than 3 diopters, even that's hard to tolerate in spectacles because the anisoconia.
Exactly. And then they're going to become amblyopic, and then, one eye forever is affected and problematic, and possibly, has vision loss that should have been reversible.
Why do you think refractive surgery in the US, like corneal refractive surgery, is not more common? Like, if you had asked me 20 years ago, I'd say it's going to become like braces for your teeth. Every kid turns about 13 or 12 or 11 years old and gets the brace on their teeth. Their teeth are perfect. Why do we not have this where kids would have, okay, you're 18, 20, 21 years old, your refraction stabilized, you do your LASIK now, you're good to go till you become presbyopic in 25 years, and then you can do something in the future.
Okay.
Why don't we have that?
Did you just read my mind?
No.
I literally was thinking it should be like braces. Refractive surgery should be like braces. Everybody gets braces, and truly you get your teeth corrected. Why don't you get your vision corrected? Why is it not that concept?
Tell me. I'm not president-elect of ISRS. You are. You tell me.
Okay, well, I'll tell you. I think that we need to really think about the safety of these procedures. And do we need to wait for refractive stability to intervene, right? Like, do we need to wait? Why we're waiting for them to reach that peak, but if we intervened early, maybe they wouldn't peak. Maybe we could, if we intervened and did a procedure that helped them decrease the peripheral hyperopic defocus on their cornea, on their retina, maybe then their eyes would stop growing.
That's a good point.
See that? So I think the key is we have to think about this more holistically. And when should we intervene? I think that we all see contact lens related infections.
Yeah. It can be devastating.
Every week, blinding contact lens related infections, right? So we know contact lenses are not the safest thing. And we know our children want to be super active. So we need to think holistically and kind of globally about this issue. And we need to establish safety. We need to establish predictability. We need to do those studies. And we need to really think, from first principle, like what is happening to this child as they're growing, and how can we, affect that, kind of like help them stop progressing in their myopia first, so that they do reach that point where we can intervene.
Yeah, wow, all great points. It's interesting to see what this will end up being, what
Uh,
it'll evolve to.
Oh yeah, absolutely. I mean, well, I think that the field of myopia control and refractive surgery obviously, are so intertwined.
Yeah,
And, so every single patient I see for a refractive surgery consult, I discuss with them myopia control for their children.
mm. Oh, that's smart. Because obviously their kids are gonna likely be myopic
Uh-huh.
too.
Yep.
Yeah.
Yep.
And you look
So
at some cities like Singapore or Hong Kong or Taipei, where the incidence of myopia among young people is like incredible, like 80, 90%.
yeah, exactly. Exactly. I mean, this is, as we all know, right, the myopia epidemic. And this is how I've started to say it now. Myopia is not just a refractive condition, it's a disease. It is a true
Yeah.
disease. It is associated with glaucoma,
Yeah.
with myopic degeneration of the retina,
Yeah. Detachment
with retinal detachment, right?
with
Like,
earlier cataract
yeah,
development.
earlier cataract. So that's a disease. Like all those things we talked about, that is a disease state. So
Yeah.
myopia is a disease. We need to really start attacking this disease in our earliest form, and I think we really need to jump on that bandwagon. But I'm
Yeah.
with you. Yeah, no, I think we should not let these people get to -9s. I think we need to try to make help them, these children, stop progressing.
What? I think great points, great stuff. Yeah, interesting to see where this will end up going. We'll find out. Now, tell me also about your interest in acupuncture. People may not know.
Acupuncture. Oh my gosh. Yes, I am a licensed acupuncturist. But then you did a lot of research. I'm super impressed with you.
I've only known you for 20 years.
Good point. So I became a licensed acupuncturist in 2007.
Wow. Okay.
And I was, doing my career, going along, and I then had an acupuncture treatment, and I was in the Lake Austin spa. Still remember, and I had some back issues, so I was like laying there with these needles in my back, thinking, "This is unbelievable, right? This discipline, 2,000 years old. We
Wow.
are still doing the same thing. This person is sticking needles in my body to
Wow.
affect my pain. What is this? I need to learn this. This is the coolest thing." And what are the applications for ophthalmology? So that's when I had my little epiphany
Okay.
in Austin. And then I came back to the University of Pittsburgh, and my chairman at the time was super supportive. And he's like, "Yes, study it. I will give you the resources and I will give you the time needed. You become a licensed acupuncturist." And really then, start looking at the applications in ophthalmology. So it was super, super excited. So I then studied, and I did this course that was through UCLA. And it
Hmm.
was acupuncture for MDs, basically, so that they accelerate the course. And it was basically a year. We did about 5 days on site, and then we did 300 hours of self-study.
Well, there you go.
Oh, yeah. Oh, yeah. And then we had a final practicum that was another 10 days. And that was hands-on. We were blindfolded, and we had to find acupuncture points on a body blindfolded.
Wow. Wow.
Like, this was intense. I had to relearn all of my musculoskeletal anatomy. I was like, these actually not relearn. I mean, these were things I had never learned, like, like these little prominences and these little protuberances, and, this little point is here. And you learn a totally different language of the different meridia.
Huh.
And oh my gosh, talking about an amazing way to expand your mind and to just learn something totally new and just take that leap of faith, right?
Right.
Of this kind of Eastern type of healing methodologies. And it was fabulous. Absolutely fabulous. And the pinnacle was that during the last little session, we could invite patients. And can you imagine, the last session happened to be in Pittsburgh. So I was so lucky. I invited my nurse Nancy, who had her foot run over by a golf cart.
Okay.
And for 2 years, she was limping because she had so much pain. She saw orthopedic surgeons, she saw chiropractors, she saw foot and ankle specialists, she saw this, that, whatever, pain medicine people, no relief. So I invited her to come to the course, and we did this acupuncture treatment in her where we stuck this needle like this long in her interosseous ligament between her tibia and fibula. And we stuck it through there, and then we stimulated it, okay, mechanically. So it was like vibrating. Okay. And then she had to walk around. And you will not believe it, her pain ended that day.
Whoa, that's so amazing.
And never came back.
That is unbelievable.
One treatment. It reset all her pain receptors in her leg. It was unbelievable, right? And oh my gosh. And so then I learned these protocols for acupuncture for dry eye. Mm-hmm. I learned protocols for acupuncture for dry macular degeneration. And we've done pilot studies on those two things. But it's powerful. Acupuncture is an incredibly powerful technique. I think that all of us should open our minds. Have you ever had acupuncture, Uday?
Never, but I need to know, what are the ophthalmic applications, and where do you put the needles?
Okay, so where do you think we put the needles?
I don't know, like a retina guy, intravitreal or something. I don't know.
Okay, that's for glaucoma. That's the glaucoma protocol, when we just stick it in the eye and let the aqueous come out. That treats glaucoma. Okay. No, I'm joking. So it turns out that the ear, okay, and the finger, that's where, for the dry eye protocol, that's where we put the needles. The ear is incredibly powerful. It's like kind of like a mini, you see this like homunculus on the ear as representation. So some people just do auricular acupuncture, and they can treat a lot of different things. Well, anyway, so that's where you put for the dry eye protocol, it's in the ears and the fingers. And then for the macular degeneration protocol, there's a lot of needles, and there's some in the orbit, there's some in the scalp, and it's pretty intense. That's a very intense protocol.
What gauge are these needles? How small are these?
They're tiny. They actually, so the cool thing, when we say needle, we think of a hypodermic needle where we're drawing blood. No. Like you can put, 20 little acupuncture needles into a little hub of a hypodermic needle. They're so thin and flexible. The idea of an acupuncture needle is that actually the acupuncture needle slides between cells. It does not impale the cell. So the idea of the needle is that you're putting this needle in between the cells, and it's going and activating a point, an acupoint. And that point will then allow your chi, QI is chi, to then become unblocked. Because the concept of disease is when your chi is blocked, you form a disease. So when you can get the establishment of chi, the flowing of the chi throughout your body, then you're you're well. You don't have disease or dis-ease, you're at ease. So, the idea is that you want to maintain this beautiful kind of chi flowing throughout your body. And if you get a blockage and you have a disease, then you go and you get you put needles in these certain acupoints, and then you can kind of get rid of the blockage, and then you get flow again.
Like I have a little bit of a rotator cuff injury from too much weightlifting. I may want to check this out. I mean, what's the downside, right?
Listen, very little downside, but here's the deal. you have to find somebody who is a true healer, like a very good acupuncturist. It's just like any profession, right?
Mm-hmm.
There's some people who are really good, and there's other people who may not be so good, right? And so you can't just go to one and say, oh, acupuncture doesn't work. I went, it's useless, da da da.
Yeah.
You have to really, do your research, find out who's getting great results. And if you do find a true healer, it's like magic. It is absolutely like magic how powerful the technique is. And I've witnessed some of these things, and it's truly, truly mind-boggling.
Boy, I like your story of Nurse Nancy. Wowza.
No, right? So we started the Center for Integrative Ophthalmology at the University of Pittsburgh, and we started that back in 2007. So it's exciting that, we talk to our patients about all these kind of holistic ways to treat disease, not just, take the Restasis. We talk about behavior modification. We talk about diet. We talk about, all these different things, because really we need to take a step back and think about our patients as people.
Not just eyeballs.
Not just two little eyeballs, right? And sometimes we only think of one little eyeball, but I always step back and I always freak people out. So there's another thing I want to share with you, Uday, because I know if I say it here, like millions of people are going to know this all of a sudden. So this is fantastic. This is my other thing that I'm trying to get out there. So there is a condition called like nasal lash deviation. Okay. And what that is, you're going to notice this now when you look at your patients, and you should have them look up, down, left, right. And then when you're looking at the slit lamp, you have them close their eyes, and you're looking at their lashes. You're going to see that some people's lashes, instead of coming down, they're going this way towards the nose. Do you know why that is?
No.
Because they're sleeping with pressure on their eye all night. And their lashes are getting pushed over, and they're putting too much pressure on their eye, and their lashes literally are pushed over. So yes. And in addition, they're probably causing more keratoconus on that side, and maybe even optic nerve damage by the pressure going up at night.
Wow. I never even thought of that. That's so wild.
Uh-huh.
Learn something new every day.
I'm glad. Yes, indeed. So the nasal lash deviation, now that I told you about it, you're going to see
all the time.
in everybody. So what I do is when I see my patients, I always do that external eye exam, up, down, left, right, because, you can see those floppy eyelids, highly associated with, keratoconus, etc., sleep apnea. So I always do that external exam, and then I tell the patient which side they sleep on.
And they're probably blown away, like, what?
They're freaked out. They're like they're thinking, okay, this lady is serious. She's stalking me at night. She's a little scary. I better tell her the truth, right? And so, but then we talk more, and really, I mean, some people, I have to give them a shield to wear at night, and and it's changed their pathology. Like they wake up and they don't have pain, or they wake up and they don't have blurred vision. They wake up and they, have so much of a better, situation first thing in the morning, because they're not smushing their eye all night.
Oh, I gotta look at this now, especially the patients where, like, you see keratoconus, but it's way more in one eye versus the other eye.
Yes,
makes you wonder.
Exactly. And that's, been the sleep position, and keratoconus definitely has been associated, but not the lashes. Like the lashes are just telling you the whole story. That's why the nasal lash deviation. Boom.
You've always been one of the smartest people I've ever met in my life. let me tell you, for people who don't know, I mean, you hammered through undergrad and med school at Northwestern in 3 weeks. You did all of them, both degrees. You're like a superstar. I learned so much from you. Oof, that is fantastic. Well, I will look for that. That's actually a really great little trick, a little pearl there. That's an interesting thing.
It's so easy to see. And once you start looking for it, I'm telling you, the residents and fellows, they say to me, they're like, this is so obvious. Once you know what you're looking for, it's like, boom, literally like slap you in the face obvious every time. And then we just start documenting it. And we're doing actually a prospective study at the University of Pittsburgh, looking at this sign, how it's correlated with keratometry and optic nerve.
That is so cool. Wow. I always learn so much from DP. Such a pleasure talking to you.
It's both ways, Uday.
I'm going to learn even more at this ASRS meeting when I show you these crazy cases, and you're going to say, what are you doing? No, you should do it differently.
Just say no.
Yeah, for sure.
Say no.
Well, I want to thank you for doing this podcast. I really had a fantastic time talking to you, as always. So much to learn. I'm going to feature your video about squeeze and chop tomorrow. If you listen to the podcast live, it'll be that Monday video. Please send that over. Thank you again.
I will. Oh, the time's up already. That was so fast.
Is this too much fun? Or time flies when you're having fun.
Oh my gosh. Well, thank you for being literally the best teacher in our field.
Oh, you're too sweet.
You truly, Uday, deserve every teaching award out there because you impact more people than anybody else on this earth. So thank you for teaching all of us forever.
Oh, thank you. Remind our viewers and listeners, new podcast every week on Apple, Amazon, Spotify, Google, YouTube, anywhere you find podcasts, you find the Cataract Coach podcast. And check out our website for a free daily video. And DP's video is tomorrow. Come learn more from Cataract Coach and Dr. Dhaliwal, who again will be joining us with Dr. Rosa Bragamili for the Best of Cataract Coach session at the ASCRS meeting in Boston on Saturday, April 6th at 8 a.m. sharp. We got a full 90 minutes of amazing cases and audience interaction too. I promise you'll learn a lot.